Hello everyone, good evening. Today's session will be session 20, other lung tumors. Let's enjoy the chest radiographs with Dr. Y. I am Dr. Y, chest radiologist, medical professor working in South Korea. Review of session 19, missed lung cancer. Hello lung cancer. We don't miss you. Actually, we hate you. It's a joke. Why do we miss sometimes the lung cancer? And we always want to find out the lung cancer as early as possible. Okay, A. Lung cancer usually diagnosed in late advanced stage. That's why the prognosis is so poor. B. Lung cancer grows so fast, regrettably so fast. C. Quit smoking is for now the best policy. D. To smoke or not to smoke, that is not a question. Just don't smoke. We remember these yellow targets. Where are they? These yellow areas are the places where sometimes the lung cancer ambush himself. These open lung field, peripheral lung zones are better placed to detect lung cancer. Let's get into the session 20, primary lung tumors other than lung cancer. These 5 categories are good enough for us to study because they are not common compared as lung cancer and they are not so severe as lung cancer. A. Hamartoma. B. Salivary gland tumors such as adenoid cystic carcinoma, mucoepidermoid carcinoma. C. Carcinoid. D. Sclerosing pneumocytoma. E. Primary lymphoma of the lung. Session 20, lung neoplasms. Let's compare the lung cancer and other lung tumors, and let's remind ourselves why the lung cancer is so important to us. Lung cancer is the most common lung neoplasm. Other lung tumors are not many, even rare. And lung cancer is terrible disease, as we know, but other lung tumors are not so severe. Lung cancer has close relationship with smoking, so quit smoking is a good choice, but other lung tumors have no such relation with smoking. Let's go to the hamartoma. Hamartoma is the commonest benign nodules and 3/4 of all benign lung tumors. Hamartomas are made up of normal mesenchymal tissues such as cartilage, connective tissue, fat, and muscle in abnormal amounts. They are usually less than 4 cm in size. They usually show fat component and sometimes pepcone or stippled calcifications. Pepcone calcification is somewhat characteristic of hamartoma in the CT. Their location is usually peripheral in 90%. 2. Salivary gland tumor. Adenoid cystic carcinoma is 4 times more frequent than mucoepidermoid carcinoma, and adenoid cystic carcinoma usually located on the more central airway, such as trachea and major bronchi, and mucoepidermoid carcinoma is in more distal airway, such as segmental bronchus. Anyway, both of them are located usually in the large airway and show no specific findings. Number 3. Carcinoid tumor. It's a neuroendocrine origin, and it also has predilection for airway location. They are rare, and typical carcinoid compose almost 80%, and atypical carcinoids is 20%. Mean age is about 45. Typical carcinoid usually shows as solitary pulmonary nodule. 85% are in airway, major to subsegmental bronchi, and 15% are in peripheral location. They usually show the face of iceberg tumor because the extrabronchial component is much bigger than intraluminal component of the tumor. B. So they usually shows consolidation, atelectasis, and mucoid impaction. And they show strong enhancement in CT because of their rich vascularity. But they show poor uptake on PET-CT because their glucose metabolism is not active. An atypical carcinoid is more high-grade, aggressive than typical carcinoid, so the prognosis is not so good. 4. Sclerosing pneumocytoma. We used to call them sclerosing hemangioma, but it was proved that their origin is pneumocyte 2, type 2 pneumocyte. It's a very rare benign tumor, more frequent in young women. They usually show the well-defined, small, round nodule than mass. Sometimes they locate in juxtapleural location, more on the left side, and sometimes they are in just around the major fissure or minor fissure. The last one, primary lymphoma of the lung, very, very rare. They are usually low-grade B-cell lymphoma. We call sometimes martoma or bartoma, mucosa-associated lymphoid tissue lymphoma, or bronchus-associated lymphoid tissue lymphoma. It is of non-Hodgkin's lymphoma. And high-grade B-cell lymphoma and lymphomatoid granulomatosis are very, very rare. Primary lymphoma of the lungs are very rare, as I have told you. Only 3% of extranodal lymphomas are lung lymphoma. And they show protein findings such as nodule, mass, ground glass opacity, and consolidation. Let's enjoy the chest radiographic findings of other lung tumors. What do we see? 1 centimeter nodule in the left side of middle lung zone, probably behind left heart. So it is in left lower lobe in young women. How does the nodule look like on this coronal non-contrast enhanced CT? Yes, 1 centimeter well-defined nodule with peripheral calcifications and suspicious fat density, low density in the central portion. Yes, this was proved as hematoma. What do we see with this young lady's chest radiograph. Yes, 3 cm, well-defined, dense nodule, not overlapped with the right heart border. So it's in right lower lobe. Yes, correct. What about this one? What is this? Yes, bronchus intermedius. Bronchus intermedius is above the mass and no distal atelectasis. This is actual non-contrast image. What do we see? Yes, well-defined mass with internal steepled calcifications. Steepled calcification. How about this coronal image? Yes, same as the frontal chest radiograph. Just at the distal portion of intraluminal bronchus intermedius, there's a mass here. 3 cm mass blocking the bronchus intermedius with steepled calcifications. What is this? How about this frontal radiograph? Yes, what do we see? Yes, many calcifications here. Something like, yes, popcorn or steepled calcification. This is the CT of her image. Yes, this is middle lobe with, do you like popcorn? How about this appearance? Popcorn calcifications. Yes, this is hematoma. There is another famous popcorn calcification in the breast. Do you remember? Yes, popcorn calcification of breast fibroadenoma. This is hematoma, popcorn calcification. What about this frontal radiograph? Please look at the distal trachea on the left side. You got it? Right distal side looks okay, but left distal side is not looking okay. Yes, bulging mass here. What is this? Distal tracheal tumor. Please look at the non-contrast enhanced axial CT of distal trachea. Yes, left side intraluminal bulging mass without characteristic findings. This is the actually adenoid cystic carcinoma, second most common tracheal tumor. What is number 1 tracheal tumor? It's squamous cell carcinoma. Yes, second most common tracheal tumor is adenoid cystic carcinoma. What about this frontal radiograph of a young woman? Please look at the distal right main bronchus. Do you see something? 2.5 cm ovoid mass blocking the distal main and bronchus intermedius, right? And what about the distal collapse? That is the famous combined collapse of right middle lobe and right lower lobe. Let's see the contrast enhanced axial CT. This is contrast enhancing mass, intraluminal mass of distal main bronchus and bronchus intermedius. Yes, we see here. Yes, this one. Mucoepidermoid carcinoma without so much characteristic findings. Do you remember this image? Remember? Okay, very good. What is this dense triangular shaped lesion here? This is a cardiac border. Yes, left lower lobe collapse. We have met before. Yes, this is the tumor margin. Yes, we remember this one. Characteristic left lower lobe collapse with mass collapsing left lower lobe. Look at the contrast enhanced axial CT imaging. This is well enhancing mass of left proximal bronchus with distal collapse. What do we say this finding? Yes, Golden's S sign. Distal collapsed lung, proximal tumor here. Left lower lobe collapse with a strong enhancement in CT. But look at this. In contrast, on PET-CT, there is no remarkable uptake in carcinoid tumor at PET-CT. These two findings are most characteristic findings of carcinoid in more favor of typical carcinoid. How about this radiograph? What do we see? I don't know. I'm not sure. But I suggest, how about this one? Maybe or maybe not. Let's look at the axial lung window setting, thin section CT. This one. This is major fissure, juxta, pleural location, 1 centimeter at left lower lobe. Yes, this was proved as sclerosing pneumocytoma. This is contrast-enhanced coronal CT. Not characteristic, just small nodule with just mild enhancement. This was proved as sclerosing pneumocytoma. How about this imaging? What do we see? 1, 2, 3, maybe this one, this large one below the minor fissure, and this one, this one, this one, this one. Yes, we see multiple ill-defined nodules or consolidations. What are these? Without significant symptoms and no change for several days, so we biopsied. This ground glass opacity consolidation. Yes, it was proved as martoma. Lymphoma of primary lung. These are two thin section lung window setting CTs of upper lung zone and lower lung zone. Yes, we see many ground glass opacity and consolidation, multifocal. Yes, this is martoma, baltoma. Very, very rare. Yes, we finished session 20 of other lung tumors, not lung cancer. Was it interesting? I hope so. This is the answer for the previous medical exam case. Number 1, COVID-19 pneumonia, bilateral, subpleural, peripheral, multifocal, symmetric GGL consolidations. Yes, this is the relatively typical findings of COVID-19 pneumonia. Are you correct? This is the answer for the medical exam case 2, mucinous adenocarcinoma. Yes, we see in this relatively middle-aged woman. Yes, retrocardiac, left lower lobe consolidation with air bronchogram. On the CT, air bronchogram consolidation with relatively low density of consolidation. That's why it's mucinous adenocarcinoma. Are you correct? Congratulations. Medical exam case number 3. She has a history of tuberous sclerosis. Diagnosis, please. We may see many cystic lung lesions, numerous cystic lung lesions in this young woman. Answer, please. Medical exam case number 4. What is this thin line? What is the name of this thin line the yellow arrow indicates? Answer, please. This is the last slide of this session. Where have all the handsome, brave, romantic Marlboro men gone? Do you know? I don't know. Like, subscribe will be a big support to me. Thank you very much and have a good day.